Thank you. Those were really exciting, really awesome talks. I think that I'd like to be the first person to ask a question today. I have that prerogative since I have the mic. Do you think that the communities of clinicians, physicians, physician researchers, and basic scientists are doing enough to work together to translate discovery into clinical practice?
I'm not a clinician.
Someone controlling the mic?
Yeah, you can.
Okay, so from my perspective as a clinician, I can tell you, having applied for grants to certain organizations, I've been told that they only give grants to universities. So the problem that I face right now is I've been using these mycobacterium drugs for the last couple of years against, and exactly some of the work you saw before with biofilm busters, and my wife, who's had Lyme for 22 years, is now in remission for 11 months with not one symptom. I told you yesterday, Olivia, the 14-year-old from Colorado, who HIPAA reasons I can tell you, she's going on 3 to 4 months without any symptoms since doing this dapsone combination therapy. There may be a patient in this room who I can't say who has done the dapsone combination therapy who is much better. I'm definitely having success, but the problem I face now is I need to convince the scientific community of what I'm finding, and I need to do a multi-center study. So the question is, I would love to have a lab. I spoke to Dr. Zhang yesterday about this and say, hey, Ying, can I send you those 30 people? We have a new study we'll publish next year on dapsone. 80 out of 110 had a great success with a double-dose dapsone protocol, but 30 failed. They all seemed to have Babesia and Bartonella, but maybe they had something else. I'd love to have a great lab to be able to send those bloods to and be able to coordinate, right, with a whole team of people so I can find out why my patients are sick. And unfortunately, we don't have that network at this point that I can just send, those cases to researchers. And I think as a clinician, I can tell you, I've been publishing the last few years as much as I can, but I don't think that clinicians like myself are actually being supported in exactly the same way as university-based researchers. And I feel it's a shame because I've been doing this for over 30 years, and I actually feel like I'm very close to a durable solution. I don't know yet. I still have to send out a survey monkey on these patients who've done the double-dose dapsone, but I'm not getting phone calls and emails back. So I do feel that there needs to be more work together. I think the Tick-Borne Disease Working Group has done a great job, actually, at bringing both sides together. The subcommittees, we had very honest conversations. I had a chance to speak with Rod Smith from the IDSA. We had very good conversations. Wendy, you were involved in those conversations. It's the first time, really, that both sides have come to the table. So, but I can say as a clinician, and I know there are many clinicians in the audience, I'm wondering if they feel the same way, because a lot of us have different perspectives, but when something new that's working really well is out there, we want to get it out for the Lyme community as much as possible, and I think getting people together would be helpful.
Dr. Chandra?
Well, and were there two components to this question? Sorry. Okay. Were there two components, one being are clinicians translating the research into their daily practice also?
Yeah, the ability to translate and the pace at which we're doing so currently.
Okay. Well, I think there are two categories of clinicians. There's clinicians who are, like Dr. Horowitz and myself, trying to keep up with the literature and translate it. But there's another group that's larger in the doctors who are not looking at the literature and practicing the same way as they were trained during medical school. And the problem is that group is still larger, and we're not reaching them. And they're the ones who are seeing most of the patients. So that's one. And the second is, I agree with Dr. Horowitz, is that most of us who are out there every day seeing patients, we have data because we're seeing them. We're collecting it often in EMR, but not in a way that we can mine it and really answer these questions. And I would love to be part of or learn about a way that we could take this data that's being generated and learn from it.
Can Dr. Horowitz comment on Dr. Chandra's theory that probiotics are not sufficient enough to maintain the microbiome? I understand Dr. Horowitz uses probiotics a lot. Does he think his probiotics are sufficiently sustaining patients' guts?
Yeah, so, it's interesting. I think most of you probably know that 60 to 70% of the antibiotics that get into us are from animal feed, not from doctors like myself that give antibiotics to patients. That's a whole nother issue. But it's not just from doctors, and you saw that even a 7-day course of amoxicillin can affect the microbiome. So we've been using a minimum of 3 probiotics over 200 billion with Saccharomyces boulardii. We keep replacing the microbiome when we're done. Now, I follow these patients, as an internist after they're done. I haven't seen any long-term health consequences. I've not seen increased risks of cancer. There were studies actually years ago about breast cancer risk and changing the microbiome with antibiotics. I personally have not seen it at this point. And the thing is that the protocol that I'm trying to work on at this point is this new dapsone protocol, which is not what I presented to you today, was a 7-week protocol. This was in patients who just did 7 weeks of antibiotics using these persister drugs and biofilm busters, and I have to track them, but it's a short course. Now, that will still affect the microbiome, but it's not months and years of antibiotics, and I think the only way we're going to get acceptance is much shorter courses. But like with tuberculosis, nobody would say, oh, only give it for 1 or 2 months, right? You've got to use, for some of these persister bacteria, longer courses. But I think the key is you've got to replace the microbiome as best you can. But when I've looked at Ubiome and some of these companies that check it, I have not found them to be yet, à point, excuse my French, to really get it right, because depending on where they take the sample, I've seen that they've seen different results. So I don't think we're yet, there with it. I think it is a concern. But I think you've got to do what you've got to do for patients and do your best, and I haven't seen long-term health consequences at this point.
I just want to comment on the microbiome stuff.
Please.
Am I on? Hello? Okay, so so there's a study that just came out very recently from an Israeli group in the Weizmann Institute, which is pretty interesting on microbiome in general. If you're interested in probiotics specifically, as they looked at, it's a very detailed study on do probiotics that are consumed as part of diet graft essentially into the microbiome. And actually what they found is they for the most part don't graft into the microbiome. They just kind of pass through. Doesn't mean they're not having biological effects as they're passing through, but they don't really graft well. But they did actually identify components of microbiome, characteristics of people's microbiome that would help their probiotics graft well. And actually, if I remember correctly from the study, it just came out, actually, I think using antibiotics prior to probiotics would help sort of scorch the earth and then reseed some of the microbiome, or something like that. You should read the study. The second thing I want to tell everybody who's interested in microbiome is that we're just really getting started with microbiome again. So it sounds like companies like Ubiome and others have been around for a while, and there's lots of academic studies. But it's really, they've used a sequencing technology called 16S, ribosomal RNA sequencing, which is really looking at one gene to sort of describe your whole microbiome in some way. So now we're just starting to get large data sets that look like a shotgun metagenomics, which is more whole genome sequencing of the whole microbiome. And we're just starting to get those data sets, which will tell us much more about not only who's there, but what bacteria are active and what genes they're expressing and things like that. So even though everybody's excited about the microbiome, we're kind of just getting started.
One other quick thing about it. One of the probiotics we use, they have shown that the stomach acid gets rid of about 90% of whatever you take in. One of the probiotics we use has a sodium alginate coat, and they've shown that 95%, this company has a patent, 95% of these 40 to 60 billion of these 5 strains that have been published in the literature in over 100 studies in octogenarians, people that have lived the longest. Those are the strains we're using, and they've been published in the literature as functional probiotics. They've helped with irritable bowel, IBS. So we actually looked at the strains that we're using in our patients, and there are studies published years ago on Saccharomyces boulardii helping to stop C. diff diarrhea. So at least as a clinician,
sure.
I'm finding antibiotic-associated diarrhea has been much less, right? And as long as patients are compliant with what we're giving them. Yeah.
I think this is a really nice follow-on to the conversation about gut health and microbiome. This is specifically to Dr. Horowitz, though I think anyone can answer. Dr. Horowitz, have you used fecal restoration for your patients? And if not, would you consider it?
I have, but only on rare occasions. I'm hesitant to tell you one of my secrets, but since someone asked the question, we will do probiotic enemas. And I learned about this from David Perlmutter, who's a functional neurologist. They did a study in the autism population where they replaced their microbiome and changed it because they found that there are certain species in the gut of the autistic population causing propionic acid to be produced, which causes some of the neurological problems. And 2/3 of that autistic population did very well with probiotic enemas. So what I've done is I've looked at the literature. We have certain companies we use specifically, and we've done probiotic enemas using over 1 trillion of these different strains, especially different strains like bifidobacterium that are anaerobic that get into the lower intestine. And if you look at bifidobacterium and you look at the literature, there's a lot of science on it, helping with upper respiratory infections, different things. So I think there is a lot out there, and of course I have not been able to do microbiome studies after doing this, but it's only been actually in my career probably 1 or 2 cases that have actually had to gone for fecal transplants. But the key is, and I'm sure someone will talk about this, they've now shown with diabetes and metabolic syndrome, right, that you can replace it and you can stop, people with diabetes. So I mean, there's a lot coming out on the microbiome and other effects on health, and we're really just at the forefront of it at this point.
Okay. Dr. Chandra, given the increasing recognition that antimicrobial treatments for tick-borne diseases can harm the patient, do you think more emphasis should be placed on prevention, specifically tick control? Why do you think tick control has been so underemphasized?
That's a little.
That's a big question.
Because I haven't been as involved with that, especially since I see patients after. But I agree, it takes so much to help these patients, as I talked about the lost years and the resources. So anything we can do for prevention would be preferable, but I don't know all the things that are being studied in ecosystems in terms of tick control. I don't know if either of you have more information.
We had a discussion about it yesterday, some of us, and there's a technology that's cool but also scary called gene drives, where you can eradicate some species if you so choose. And it was determined, I think, that someone looked at mosquitoes, because I hate mosquitoes, and that someone's done an ecological analysis that, it would be okay to get rid of all mosquitoes. I'm not convinced. I think the whole food web could unravel and we'll all die, but who knows. But so a similar analysis was not done on ticks, as far as I know, and maybe there was. So that type of analysis hadn't been done, the effects, as far as I know.
And again, I think we have to be concerned about what we do to change the ecosystem. But what I recommend to my patients, because often they're scared, will I get another tick bite, is say, well, what can you do to be more resilient? So we can't avoid all these exposures, but again, looking at stress, nutrition, are you getting enough zinc? How is your microbiome? That's what I really try to encourage, because we have more control, and I don't want my patients, as a psychiatrist, to feel fearful. Especially we're in Northern California, it's beautiful to go hiking, so I don't want people to be afraid to go into nature.
Yeah, and regarding the prevention aspect, if those of you who have not gone online and taken a look at the subcommittee reports from the Tick-Borne Disease Working Group, there's a lot of work that went into prevention and surveillance. So there are multiple studies. I think it's a 150 or 180-page report for those of you who want to see about surveillance, prevention, and the rest. And I know, Jill, you've been working on Stop Ticks for a long time at this point, but absolutely. I mean, but as primary care physicians, we need to do a better job, just like we talk about colon cancer screening, prostate screening. The next step has to be, are you using permethrin-treated clothes? Are you using IR 3535 picaridin? Are you doing things around your home? Are you checking your pet? I mean, there's a lot that people can do, but it's getting to the point that should be standard care, right? Not just go for your cardiovascular screens and your lipid profiles. Keeping ticks and mosquitoes in line now, I think, has become essential.
This is an interesting question. Dr. Zhang, this is to you in the audience. Is the cinnamon the true cinnamon or the one commonly used as a public seasoning?
It's cinnamon bark oil.
Cinnamon bark oil.
Yes.
Okay.
It's one of the most active experimental methods.
Very cool. I agree. That was a very exciting study, and I really enjoyed the poster presentation yesterday as well. Thank you for sharing that. And Joel, thank you for bringing it up today. Dr. Horowitz, what role does oxidative therapies play in healing Lyme, and at what stage would it be most effective?
So it's a good question. So a lot of what I try and do is to shut down the inflammatory process, because the cytokines are what's keeping Lyme patients sick. But just like when you drive a car, you don't keep your foot on the gas all the time. You got to put the brakes on. There are groups of patients that have done oxidative therapies like ozone, hydrogen peroxide, and the rest. And I have heard some, positive clinical results. Now, I think one of the things I would like to see is, the NIH Office of Alternative Medicine was started years ago, but I would like to see those kind of studies done in a real rigorous scientific manner, because people come in who've done long-term ozone therapy and tell me they burned out their veins, or they've done high-dose IV vitamin C, they burned out their veins. Clinically, I hear that there are some results, but I don't think it's enough based on what we know now with the science, with persisters and biofilms. and changing forms with cell wall forms, round body forms, intracellular, biofilm. I think you've got to take into account the full biology. But from a clinician standpoint, what I hear from patients is there is some benefit, but I think we need more rigorous studies.
I like this question a lot, and it's to anyone on the panel. What role can functional medicine health coaches play in building resilience?
So that's a great question, and that's something that I'm working on right now to bring in a health coach, because so much of this type of preventative care can be done by someone who's educated, but not a physician, in a way that's also more affordable, and then also more accessible. So you can meet with somebody initially maybe on a weekly basis as you're looking at diet, as you're looking at stress. And a lot of our patients need that level of hand-holding. And also they have brain fog sometimes, so they need that level of organization. So I absolutely think that there is a role for health coaches to help guide our patients in some of these things that are essential to getting well, but not necessarily medical.
Dr. Chandra, still with you. Do you find most of your patients who suffer Lyme have been referred to you because other doctors have told them their disease was psychological or in their head?
So no, because I don't get referred by other doctors. And most of my patients find me because a friend or family member said something similar happened to me. So the good thing is they come with hope. The person who referred them got better and has hope, as opposed to them feeling like they're being dumped by a clinician. I think the patients that are told it's not in their head, I'm not sure who that they get referred to, but because I'm integrative and I'm looking at other biological factors, I wouldn't see them necessarily.
Sure. But maybe the panel can speak to that. I think that that's a very valid and true experience that a lot of people have felt in this community. And being told that when you feel absolutely terrible that something is in your head, or, or even dismissed as psychological. And psychological, in my opinion, is our brains are amazing, and they can make us, the way that we see reality, that's not something to be dismissed. So being in your head is still real. But perhaps you can talk about this as an experience from the clinical side, as seeing patients who feel like they may not be validated in the traditional system.
Well, and that often happens. I think the majority of patients at some point have felt invalidated. And with some of my patients, we've talked about not just trauma as we think about it, but medical trauma. And that's been very helpful to the healing process, because they realize that that level of invalidation over many years really made them feel out of control and scared in the same way that we think about other traumas.
So I would say now, where the science is going, now you can say, if someone says it's in your head, you can say, great, here's a bunch of papers that tell me how my head is connected to my rest of my body. Can you treat these? So a great example, there's a paper on just last 2 weeks on the vagus nerve, which a lot of people wear the vagus nerve, but there's an amazing paper, I'll try to remember eventually where it was, Science Nature, one of the big, on actually decoding some of the mechanisms by which the vagus nerve regulates immune function across the body. There's a company funded here in New York City called Callio, I believe is the name of the company, targeting stimulation of the vagus nerve for immune therapy, right? So now I think what's great is the science is catching up with some of this, and where we actually, if it is in your head, that's a perfectly reasonable thing to say, because it could be affecting your immune system. And we know the mechanisms.
I actually do tell people that it is in their head. I say, you've got spirochetes in your head, you've got neurotoxins in your head. And then when they come in and say, Doc, I'm losing my mind, I say to them, well, have you ever found your mind? That stops them, by the way. That's studying with Buddhist lamas for 35 years. It's a separate joke. But the fact is you have to validate patient experience, right? I mean, and it's true, there is PTSD. I mean, they come in having seen 20 or 30 doctors, and basically they have been told that, right? It's just in their head, there's something psychologically wrong with them, and they do need validation.
Mm-hmm. This question came up yesterday, and this is a new panel. Well, I think this came up with you, Dr. Horowitz, yesterday as well. Maybe not. I don't remember. Why? Oh, I just lost it. Why the effort to relabel an already labeled disease, chronic Lyme? Dr. Alcott said yesterday that PTLDS falls under the umbrella of chronic Lyme. What criteria would disqualify a patient from having PTLDS as opposed to chronic Lyme disease? why would there be a distinction? I think that this is just, I've had this in the past few months as I've been talking about this conference, not knowing what to say, chronic Lyme, PTLDS. Maybe we could just spend a few minutes talking about those distinctions.
I mean, I think John did a great job yesterday talking about the subset. So, I mean, the PTLDS subset, they've had EM rashes, right? They've been treated, they've been given doxy, they still have symptoms 6 months going on a year. And you saw from my slides that in the data mining we did, only 19% of the patients had recognized an EM rash. Because when we were on the tick-borne working group, this came up, and in fact, Rob Smith and others had said, we don't have a definition for chronic Lyme disease. So that's why when I did this data mining study, I said, okay, let me go through the 657 volumes of charts and use the 16-point MSIDS model to say, here's a starting point for what I find in people with chronic Lyme disease, right? And the model is a paradigm shift because it's multifactorial, but it can be used, as you saw, for other chronic diseases. So I think, but even among mine, there's subsets. And I think the problem is with the complexity, there's going to be some of these subsets, right, that have co-infections and some don't. And some are going to have lots of environmental toxins and some don't, and some have hormonal disruption and don't. The problem is there's going to be a variability with subsets, and I think that's why it's got to be personalized precision because everyone is different. You can't use guidelines. You can't use whether it's ILADS guidelines or IDSA guidelines. No guideline accounts at this point for the complexity of what a patient is coming in with. So I think we need to identify those subsets that John was talking about yesterday. I think it's going to be very helpful.
Joel, when we're looking at the electronic health record and we're looking at the way that these diseases are being classified in these big data sets, is this distinction important for us researchers to understand?
Yeah, no, I mean, I think this is a challenge we have across all disease research, right? So there was a lot of the research we're doing is showing, we like to put diseases into little silos or buckets because it makes life easier to think about. But I think what the data shows, especially as we get more molecular data, that disease is a big fabric, right? And we kind of draw circles around it arbitrarily and say, this is this disease and that disease, but we need to collect more data to fill out that whole picture. So. I always say that it'd be nice that instead of having diseases, we had coordinates instead. Like this is where you are on the map of disease right now. This is kind of a bad spot for these reasons. We'll get you this GPS coordinate over here. This is better, but stop using disease labels would be my dream in the future that I might see before I die. We'll see. Yeah.
How do we build relationships between university researchers and clinicians? Are there examples of good partnerships? That's a long pause.
The only one that I can speak of, I've been working with Eva Shoppy now for quite a while. I showed you the study where she was looking at the biofilm mass using doxycycline, rifampin, and dapsone. So, I mean, I have been working with Eva, but like my dream and my goal is to, take these patients who are failing some of the therapies and get them over to Stanford or get them to Dr. Zhang's lab and do a really complete PCR analysis or of how Charles Chu, I mean, he's presented on these incredible cases that no one knows what's wrong with someone, and he runs an entire profile, right, and he finds, right, unusual diseases. I would love to be able to have that possibility, and I think for those of us who are clinicians, who struggle, whose job is to get these patients better, anything, I mean, if there's any ideas out there of how to increase the collaborations, I think, unfortunately, it's a question of money. Because if I send that laboratory work to Dr. Zhang, I mean, where is he going to get the money to be able to process? So unfortunately, it's coming down to finances, and unfortunately, our government has not really financed Lyme disease adequately. I think everybody knows by now, which is why the generosity of the Cohen Foundation has been so appreciated by so many. It's saving all of us at this point because somebody had to step up and save the U.S. because the government isn't doing it, right? So hopefully the congressional report that's going to be coming out will give Congress a little bit of a push. I think we all need to call our congressional representatives after it comes out and let them know they need to act on this and get a lot more funding.
Oh, thank you.
I'll just add on this. I think Jason hasn't spoken yet today. Jason Bobe, who's sitting back there, he's going to be running a little session on N-of-1 studies and resilience and things in Lyme. And I think what Jason has done in terms of is mapping out sort of the governance, the interaction model between researchers and clinicians at the forefront of patient care in terms of, and his interest is in resilience and identifying people who are resilient to disease. But how do you make that? How do you do that systematically? Not only from the operational standpoint, but from the regulatory standpoint, et cetera. So I think if you're interested in that question, make sure you see Jason later.
I think this is going to be our last question for the day, and it's a heavy one, but it's aligned with what we were just talking about. How is the information being shared here today being translated to mainstream doctors in the clinical setting? Patients are currently being turned away and being misdiagnosed. So I think that the heart of this question is, what can we, as people in this room today, be doing to better get this information out there and make a difference?
Yeah.
Well,
I don't put you on the spot. Sorry.
So I've spoken at other groups like this, but I think this is really powerful because it's coming from an academic center. So I think that will make a difference. And for example, if I refer a clinician that's close to me now to the same talk I gave, because it's linked to Mount Sinai, it may be more credible. So I appreciate that. What can we do on a larger scale to reach doctors? I'd love to, again, talk to you as a group about how we can do something, because we have to reach more doctors. Unfortunately, Dr. Horowitz and I are often the last resort. Somebody comes to me after 10 years. We really need to reach the primary care physicians and the pediatricians, who both can educate about prevention, but also be the first person who's going to see them, who won't invalidate them. And it won't take them 10 years to get the diagnosis.
Yeah, so I'll add, I mean, this is a problem that's in the healthcare system in general, right? I was like, if you might have heard of pharmacogenomics, using your genetics to dose drugs, right? There are some 6-mercaptopurine and clopidogrel. There's a bunch of drugs that we know, if you have genetic factors, you can adjust your dosing. It's even on the label of some of these drugs, but we cannot get doctors to prescribe based on genetics, even when people have genetics, these things that are well understood. So this is a problem in general. But I think I'll point back, some of you didn't see what I talked about yesterday, which is my analogy with Alipay and WePay in China, is that we have the opportunity with Lyme, because we don't have this institutional inertia and set way of doing things like other diseases, we can leapfrog ahead here, right? Because we have nothing. It's like we don't have the landlines even installed, right? So we can just go right to the mobile phone, right? So this is, I think, although it's dire across the industry, and we have actually a better opportunity in many ways than other diseases to jump ahead.
So I think one of the other problems is the complexity of these patients. I'll spend 4 to 6 hours sometimes doing a history and physical. I've been working on a digital model to kind of capture the data from the MSIDs, but when you're a full-time doctor doing this, it's very difficult, and I've got probably at least 8,000 charts in my office that could be data mined. I just showed you 200. So I think the issue right now is it's multifactorial. You need something simpler. They're very complex. Doctors don't know what to do with these complex patients. I say to them, hey, here's a 16-point model. It's a checklist, right? Go through it piece by piece. So the HMO model does not allow that. So I think really where we're going with chronic disease, which was part of my talk, is we need chronic disease centers of excellence. If somebody has chronic fatigue syndrome or fibromyalgia, an autoimmune disease or MS or ALS or whatever, and you're not getting better in standard medical care, my dream for the future, set up a chronic disease center of excellence where you screen with these 16 points, publish the data in the literature, but there's also the politics, right? I mean, and nobody's really talked about it, but the medical boards, this was addressed in the Access to Care Committee, the doctors are afraid to treat this because of the controversies. And a lot of doctors, some of whom are very courageous and in this room, who have stuck their neck outs for a long period of time, and hats off to them, these are what I'll call, the mensches among the group, who basically have the goodness and the morality to say, my patients come first, right? But it's very difficult. And until you change that political situation with medical boards, and it's still going on across the US, and with HMOs, that when I first discovered babesiosis 20 years ago in Dutchess County, the insurance companies didn't want to hear about the fact that I was getting patients out of wheelchair walking. I was spending too much money on Mepron and Zithromax, and they basically threw me out of their programs. And then 4 years later, Dutchess County Department of Health in New York State said, oh, by the way, there is babesiosis in Dutchess County. There's a real lag here between the politics, the complexity, the HMO models. I mean, I think you're going to have to address this really from all perspectives to really get this thing to move forward.
Well, thank you very much to our panelists. And I'm very, yes, please. There are a lot of questions that I didn't get to, and I am truly sorry that if there's a question out there that didn't get answered. Dr. Horowitz, Joel, and Dr. Chandra are going to be around today if you want to flag them down and ask the questions that you didn't get to ask in this panel session. We'll also be setting up a Twitter account where all of the questions from the past 2 days that didn't get answered are going to go live, and we're going to be tweeting out answers and beginning a much broader conversation in the Twitterverse.